Hi there, my name is Carolyn MacRae and I'm the Mesothelioma UK Clinical Nurse Specialist covering the West of Scotland region and DNS team lead for Scotland. As you know, Meso UK have been doing a series of interviews over the last several months, really aimed at keeping the community of mesothelioma together. Today, I am delighted to be joined by Professor Kevin Blyth, or as he is known to us in Glasgow, the boss. Thank you. Kevin is a Professor of Respiratory Medicine in Glasgow. He splits his time between the Cancer Research UK Beatson Institute at the University of Glasgow and the Queen Elizabeth University Hospital, where he leads the Glasgow Pleural Disease Unit. He founded and is a director of the Macmillan Scottish Mesothelioma Network and is an NHS Scotland Senior Research Fellow leading a translational research programme focused on pleural disease and thoracic malignancy. And if that wasn't enough, he is Principal Investigator of the CR UK Predict Meso International Accelerator Network. So thank you so much for making time to do this. There are clearly lots of questions that I could ask you about the work you've done and continue to do, but today you have kindly agreed to focus on some of the more challenging situations and difficult questions that patients and healthcare professionals may encounter. I wonder if, before we start, maybe you could tell us a little bit about yourself and how you came to be so heavily involved in mesothelioma care and what drives you to do it.
Okay, so I guess first, thanks for the invitation to have this conversation. So I grew up in the west of Scotland, and I grew up in a place called Greenock, which is a shipbuilding town, and so I kind of grew up around that environment. I don't genuinely think that's why I do mesothelioma research, but I suspect it is, you know, my sense of kind of passion for it is probably reflects that background. I mean, when I became a consultant, which was about 11 years ago, I joined a service at the Southern General, which is a hospital on the Clyde and Govan, again, next to shipyards. And I was in that first few years seeing lots of patients with pleural disease and mesothelioma, and we just didn't have the infrastructure to look after them properly. We didn't have a way of doing biopsies. We didn't have thoracoscopy. We were referring people for surgery, and it was just really unsatisfactory. So we started, got some funding to start a local thoracoscopy service, and started some small scale research in meso, and then it kind of grew from there. And so we built the service up to a regional service and then a national service. And so it's been a kind of 10-year journey to get to the kind of national network we've got now.
And so I know that you could fill a whole interview with things about the network, but maybe you could tell us a little bit about the team that you've got around you just at the moment.
Yeah, so we've got, I mean, I'm very, very fortunate. You know, we've got kind of a fantastic group of people, of which you're one, obviously. We work in the Queen Elizabeth University Hospital, which is where the old Southern General used to be. It's the biggest, one of the biggest hospital campuses in Europe. Within the pleural disease unit, we have now 3 consultants, Selena Sim and Neil McGinley. Selena did her PhD in meso. She was my first student in mesothelioma research. And so Selena and I have been working together in meso for nearly a decade. And we've had a series of excellent research fellows who've come through and have done research projects, but they've also contributed to building up the clinic and doing thoracoscopy and learning those clinical skills, which means that when they go off and be consultants, that they are capable of doing that wherever they settle. And then we've got two CNSs. Of course, you're one of our CNSs, and Laura's our other, who's a more plural focus. So she's a bit more hands-on, so slightly different mixture of skills. And I think that is quite an interesting thing for, I mean, we could also spend a whole day talking about the development of the nurse role in meso, but you can have quite different roles, and your job and Laura's job reflects that. And then we've got a fantastic admin support and project management, and so we have a really good team, and everybody's kind of pushing in the same direction, which is the important thing.
So in terms of today's interview, you'll be used to sort of difficult questions coming from us, but I thought maybe the best place to start was just patient presentation and sort of initial diagnosis. So sort of briefly, if that's possible, how is a diagnosis of mesothelioma made, be that plural or peritoneal?
Yeah, so the ones that we would typically get coming to the clinic would obviously be the plural cases. We'll kind of circle back to peritoneal because they can have a slightly more difficult journey sometimes. The plural cases usually present most commonly with symptoms from an effusion, so a fluid collection in the chest, and that usually makes them breathless. And quite often they'll have a scan, a CT scan, and then they'll come and see us. And the difficulty is the non-specific nature of that appearance. So meso looks like that, but unfortunately a number of benign conditions can look like that, and also some other more serious problems. Some other cancers can cause fluid in the chest, and it's, even when you listen to the patient and you hear that they may have worked with asbestos, it doesn't necessarily follow that they definitely have meso or that they definitely don't have meso. And so we need to take them through usually a series of tests or a series of steps to get to an answer. And it's also really important that that process is combined with symptom control as quickly as possible, because quite often patients are uncomfortable, they're breathless. And one of the things that I found when I started, and the reasons I developed a service, was that people were coming in as emergencies with big fluid collections, sometimes several times without a diagnosis. And so our service and many services in the UK are set up to remove some fluid, usually, just to make people feel better. And sometimes that'll give you an answer, but it rarely, if ever, gives you a definite answer that this is mesothelioma, because we don't see meso cells easily in fluid. And so you need to do some form of tissue biopsy.
And if you do a tissue biopsy, does that always give you an answer?
No, it doesn't. And that's kind of the discussion that can be quite difficult with patients, because, I think from the outside, it seems logical that when you do a biopsy, it's a yes or a no, and it should be that straightforward. Meso is difficult to take biopsies from. It's in a difficult place, so you need a specialist service to do a thoracoscopy, for example, to put a telescope in and have a look around. And when the biopsy is taken, the doctors in the lab, the pathologists, then need to be able to tell whether that's a meso cancer or whether it's a benign reactive area of thickening, and that is kind of uniquely difficult in meso. It's much more difficult than it is in other cancers, because the tissue can look kind of the same under the microscope even when you stain it in different ways. It's only showing that you've got invasion of the tissue into the chest wall, essentially, that gives you the answer. And so it can be frustrating, because it's hardest to make the diagnosis at the early on. And so sometimes you have a kind of suspicious biopsy that we then have to maybe take another sample, or maybe even keep a close eye on things before we can make a definite diagnosis.
And so how do you talk to patients with for like an initially negative biopsy, how do you have that conversation, and what would be the sort of options there?
Yeah, so it can be really difficult. I mean, the delay can be difficult. You know, that's first thing to say. You know, quite often the biopsies in meso can take longer to come back than in other cancers, so you might be waiting for extra tests. And then when you get to sit down with the patient, if you have a biopsy that is suspicious but isn't diagnostic, I think the conversation, what your next steps are going to be, depends a wee bit on how things look. You know, if you've got for example, if you've got a CT scan that shows a lump and it really does look quite suspicious of mesothelioma, but the biopsy hasn't got us there, then sometimes we can, with the experts in the NDT that we have, we can sometimes bring it all together and make what's called a consensus diagnosis, where for practical purposes we can go forward with treatment. Sometimes that's not possible, and you know, if it's really suspicious, we would often just suggest maybe we should do another biopsy. If you know, it's a kind of slightly less suspicious CT scan, then we would maybe think about waiting, but and doing another scan in a few months. But really, the patient should feel empowered to be part of that conversation, and some patients don't want to wait. You know, not knowing what's going on is difficult. So
it's important they're a part of that decision making process.
Yeah, absolutely, because and it's important that discussion is started early. You know, even before the biopsy, that you maybe say, look, you know, there's a good chance we're going to get an answer. You know, if we don't, then would you want us to maybe have another try? And so some of that helps you plan the thoracoscopy. So the biopsy test, sometimes when we do the biopsy, we might spray talcum powder over the lung to try and glue the lung into the right place. And if a patient maybe isn't fit for another biopsy, or you know, we would do that. And in younger, fitter patients where it's really, there's likely to be an immediate treatment option, we quite often don't do that. So those things we should all be discussing those things with the patient early on, and discussing the difficulties.
And you mentioned, you know, sort of fitter or less fitter patients. You know, if you have someone who maybe at presentation is particularly frail, or for other reasons, would you always pursue a tissue sort of diagnosis?
No, no. I think I mean, I had this conversation yesterday actually in clinic. Exactly this situation. You know, if a patient is older and maybe has some other illnesses that mean that even if you prove mesothelioma in the biopsy, you know for sure that they will not receive, for example, chemotherapy, because it's very clear. We need to remember that the reason we give chemotherapy or any other drug is to try and extend life or make symptoms better. And in older patients, you're going to maybe risk shortening their life and maybe make symptoms worse. And so if you know that that's the case, you need to have the conversation really early on, because it can be difficult for families and patients to understand why you're not doing a biopsy, because if you don't explain it properly, then people can get the impression that you don't care, or that their dad is not important enough to have a biopsy test. And it's really important that we help people understand that if a biopsy's got a certain risk and the result of the biopsy won't change what we do for their disease, whatever it is, then it may not be justified to do the biopsy. It may not be the right thing to do the biopsy. I mean, the conversation that you and I have with patients, the additional bit is that unlike other cancers, there is this medical legal issue around meso. And so there's a kind of unique almost indication in suspected mesothelioma where a patient might be very clearly not fit for chemo, or may not want chemo or any other treatment, but they want a biopsy so that they can have a good chance of pursuing compensation, because that might, especially in the demographic that we deal with, the amount of compensation that can come back can really help.
It's not an insignificant amount.
It can be a significant amount of money, and it can make a difference to quality of life, and it can help with stresses around, financial, what's going to happen to my family after I'm gone, and so that those are conversations that are really, they're kind of difficult to have, if you're not used to having them, because it feels like maybe it's a different part of medicine, but I personally think it's something that it should be the patient's judgment as to whether they feel that is a reasonable reason to pursue a biopsy. And if it's technically doable, then it is a reason that we would offer them a biopsy.
If they're aware of the sort of risk benefits, if you like, then.
Yeah, because I mean, the risks are fixed. The risks are relatively easy to define in terms of there's a 1 in 100 risk of this, and because we do lots of these procedures, so we can tell patients those risks, but the benefits are subjective often, and it's important that we're not paternalistic and we say, well, I don't think that getting a compensation claim is enough benefit. For a patient, that might be transformative. It might take all their stresses away, might allow them to look after their debts and their arrangements and look after their family, and if they feel that that's how they want to do it, then we would support them in doing that.
Yeah, I think it's always important to remember you're looking after the whole person and not just a part of them.
Yeah, absolutely. Yeah.
You said at the start you wanted to maybe circle round to the peritoneal patients.
Yeah.
So sorry, on you go. Sorry.
Yeah, they have a more difficult time, and we are always very keen to have the peritoneal cases come through the MDT and try and offer them as much support as we can, because they're, the pleural cases have chest symptoms, and therefore they go to the chest doctors, and the chest doctors have the techniques and the tools to do what needs done. The peritoneal cases generally maybe have some tummy symptoms, bloating or pain, or and may go to a variety of people, maybe a gastroenterologist, a stomach doctor, or a gynecologist, and then they may come to us sometimes after a slightly longer period of time with different tests, and maybe people who aren't aware of meso so much, and so it's not really on their list of possibilities. But we still we try and offer them the same level of support, and we translate much of what we do in the chest to them. So, for example, we would use things like tunneled catheters to manage fluid symptoms, and we obviously try and involve the very specialist team in Basingstoke in all of those cases. And I think that the options, that's the only way that the options and the outcomes for that particular group of patients are going to improve, I think, is if we we try and cohort them within the services that have some experience, and we get them access to maybe some clinical trials in the future.
Yeah. Which kind of leads me beautifully on to my next question, which is around clinical trials. Once you have a diagnosis established, some of the treatment options are trial-based. So, if you have a patient who comes to you and perhaps a clinical trial may be appropriate for them, how do you discuss that, and how do you, for example, randomized clinical trials where they may be faced with treatment versus placebo, or one treatment versus another?
Yeah. So it can be kind of, I think the first thing is to make sure that we allocate enough time to have those conversations, because they can be They do need some time to talk through some of those issues, which can be a bit unfamiliar. I think the first thing, the way I always start conversations when we introduce trials is that the starting point has to be that the situation that you're in as a patient, that you're having, is that the treatment, that the options that we have at the moment are not as good as we want them to be. Be it standard chemotherapy, which maybe only works in 3 or 4 out of 10 people, or in very early stage meso, where we don't have a way of curing it. We don't have a way of operating and getting rid of the tumour. So the starting point is that the options immediately before us are maybe not as good as we want. So to move that forward and try and get better treatments, that's the purpose that trials serve. And for randomized trials, I think the first issue to kind of explain to patients is the concept of randomization. And it can feel to patients like you're experimenting on them, and that they're being used to serve the whims of some research organization or some scientist. And so the way I try and explain it is that if we think about it, like say for a drug to get to the point of being in a randomized trial, which is quite an advanced stage of trial, it's a phase 3 trial, so it's the trial that you would use to prove that a new drug is better than the current drug. It has already gone through a series of steps to show that it's safe, that any side effects are acceptable, and that there is a reasonable level of confidence that it has a useful effect on meso. So that's your starting point, is that you have something which we think there's a reasonable chance is better than what we usually do. And all trials will recruit a certain type of person. So it will usually be of maybe a certain age and a certain stage of disease. And we would be saying you would fit that bill. You look like someone who would be suitable for this trial and this assessment. What we're essentially trying to establish in the trial is whether the new drug is better than the old. So everybody in the trial starts at the same position, and half the people are given the new drug and half the people are given the normal medicine. But we are not allowed to control that, because if we did, then what we would probably do is we'd pick the fittest patients and the strongest patients and for the new medicine, and then you end up with a biased result, and it can't work that way. So we're taken out of the equation. There's no human decision making. So in a sense, it's like flipping a coin, but it's a computer essentially, which will allocate you, the patient, to one of those two arms. And so what that means is that within a trial, if you've already made the decision that you're going to have treatment, you essentially have a 50% chance that you're going to have the treatment you would have anyway out with the trial. And there's a 50% chance you're going to get the new medicine. And if you've, as a patient, decided that you want to go into the trial because you want to try the new medicine, you see it as a positive, then I would see that as a positive outcome. If you're in the trial, you've got a 50% chance of getting the new drug that we think may work better. If you're not on the trial, you have no chance of getting that new drug, but you will have the standard treatment. And you obviously need to measure that with acknowledging that not all trials are positive.
Yeah.
You know, sometimes the new medicine doesn't work as well. It's uncommon, but not. It does happen that the new drug is worse. It's more common that it's just no better, and that there are risks. You know, you might have a side effect that's difficult that you wouldn't otherwise experience.
Mm-hmm.
And there's usually more visits, and so that's how I try and talk about it. Placebo-controlled trials are really only, so placebo is obviously a dummy medicine where you're getting essentially no treatment. They're really only used when there is no treatment. You know, when the standard treatment in that situation is to do nothing, or there isn't a proven medicine to compare against. So it's the same kind of conversation.
Yeah. And so most of the trials involve some form of medicine or not, but Mars 2, which has just recently closed, was comparing the role of surgery in addition to chemotherapy. And that trial's closed now, but there's still some ongoing debate about the role of surgery and whether, while we wait on the results from Mars 2, does it still have a place? Do you or how do you kind of talk to patients about that?
Yeah, it's kind of surgery's always been a really difficult topic in meso. Ever since every conference I've ever been to in meso, the surgical session is always the most interesting, because there are essentially, we've never had a strong evidence base. We've never had a really robust proof that mesothelioma surgery improves survival, relative to not having mesothelioma surgery. And I guess that's what Mars 2 will hopefully tell us, but it won't tell us anything for at least 2 years. Mm-hmm. So as you say, we now have a period of time where we either stop doing surgery or we try and navigate some sort of sensible approach to the discussion around surgery. And so I think every service in the UK is tackling this question. Our thinking, I guess, is evolving, but I can certainly tell you the conversations that I'm currently having about it with patients. I think surgery is no different to medicines in that it's not that there's no evidence for surgery, it's just that there's no phase 3. So, the most useful, most powerful evidence base to prove the place of surgery. And when we're talking about surgery here, we should be clear that we're talking about what we call radical surgery, which is doing an operation to remove as much of the visible pleural tumour as possible.
And it's just pleural patients for Mars 2, it's not?
That's right, just pleural patients, yeah. And we know for this, the form of radical surgery that was tested in Mars 2, which is extended pleurectomy and decortication, which is essentially removing all the visible tumour, which might include removing some important part structures like the diaphragm muscle or even the lining around the heart, but leaving the lung in place. We don't have proof that extends life or improves quality of life, but we do have earlier phase studies, which would be phase 2 studies, there's no randomization. So it's just a group of selected patients who have the operation and then outcomes are reported. So for example, how long those patients lived and what the risks were with the operation. So we know from those earlier studies of that operation that if you select patients at an early stage who have a certain kind of mesothelioma and don't have other major health problems, that those patients can live for quite an extended period of time that can maybe be not measured in several years.
Mm-hmm.
And so I think my view is that it's reasonable in those very early stage patients in whom the risks of surgery are probably low to explain to them that we don't know whether an operation like this would make them live longer. There are these risks that the operation may bring in terms of side effects or pain and post-op complications. And we would offer at least a discussion with the surgeon after their case has been reviewed through our MDT, and we're very confident that the disease isn't anywhere else, and they can be involved in the discussion. I don't personally think it's reasonable for us to say at the moment that we know surgery does not work and that we should not offer it, because we don't know that. That's why we've done the trial. And it's important we don't adopt a bias in either direction. But we also can't advocate surgery as being effective because we also don't know that. Mm. So I think it's until we get to that point in 2 years' time, I think it's about selecting patients using MDTs and using all our specialist techniques and our expertise and offering those people the opportunity to have a conversation with a surgeon, especially because those very, very early stage patients are probably not going to be very suitable to have drug treatments. Some of the drug treatments that are coming on stream, like immunotherapy, are quite likely to be much more suitable and maybe even only offered to patients with more advanced disease. So I think there is room to offer that conversation.
I think it's safe to say that there's lots of difficult and challenging situations and questions right the way through from before diagnosis, right the way through to treatment decisions and beyond. I don't want to take up too much more of your time, but perhaps just before you go, to anyone that's watching this today, be that someone who has mesothelioma, their loved ones, or a healthcare professional involved in the care of someone with mesothelioma, if they're presented with a sort of challenging situation or have a difficult question to deal with, what advice would you give to them?
I think it's just important that people feel empowered to expect a certain level of input from their teams. I mean, I think no matter where you're looked after, you will be looked after by people who care and who are trying to do their best for you. I think the variation that exists still across all parts of the world, and certainly the UK, is just the level of maybe very specialist expertise there might be in your own hospital. And the development of MDTs and networks is really trying to smooth out those peaks and troughs and trying to make sure that everybody's got access to someone. I think if you feel that maybe you're not maybe speaking to someone that you feel is super experienced and sees lots of meso, then just ask that person. I think sometimes patients feel uncomfortable asking, especially in the UK, we have a kind of culture of stiff upper lip and keep your head down and don't make a fuss. But it does sometimes pay to ask, is there someone local in expertise? Has my case been discussed at a specialist mesothelioma MDT? Mm-hmm. Is there a specialist mesothelioma CNS or a nurse specialist that maybe I could speak to? If that's not maybe possible, then go to the Meso UK website. There's lots of resources there. You'll be directed. You'll certainly be able to speak to one of the nurses through the helpline. if you're in Scotland, go to the Scottish National Network website, and you'll be able to see the team, and you can find contact details for your nurse. So don't be afraid to ask, I guess.
Well, thank you. Thank you so much for doing this. I really appreciate it.
No worries. Pleasure.
Thanks. Bye.
Bye.